We're ready to get started.
All right, great. So welcome everyone to Grand Rounds. This is like a very interesting and very useful topic. So thank you to Janna, Shawn, Megan, all the presenters getting us going today. I just wanted to put in a couple reminders. First, please, when you're working in virtual visits, listen to the coders. If they're seeing trouble with your notes, repair those notes and get them back in. We are still moving along, trying to recapture where we were before the COVID and pandemic hit us. Second comment is just this Friday at 4 o'clock, we are going to do an open forum for the faculty. People are welcome to come in and join that forum. If there are things that would merit from a brief slideshow, I'll put something together and start that around 4 or 4:05. If you have suggestions for things you'd want to hear, please just put them in an email and send them to me, and I'll do my best to have some information on those. So with that, I'm going to turn it over to Dr. Brandon Nathan, who will introduce our speakers.
Thank you, Dr. Neglia. I am delighted to introduce our speakers for today's Grand Rounds and thank Dr. Marmet for inviting me to participate in this really timely topic. Our speakers today are Dr. Janna Gewirtz O'Brien, who's a fellow in adolescent medicine, Dr. Shawn Mahmud, who's a fellow in pediatric rheumatology, and Dr. Meghan Ryan, who's also a fellow in pediatric rheumatology. I think all of you would agree this is a timely and relevant topic that's impacted all of us since the onset of the COVID-19 pandemic. And each one of our speakers has helped lead the efforts here at Masonic Children's Hospital and even regionally and through our local AAP chapter here in the state. Today, they're going to provide us an informative and I think really practical discussion on the rise of telehealth in pediatric medicine since the onset of the pandemic and what we might expect to see as we look ahead into the near and distant future. Emily is going to help us moderate the chat today, and there will also be an opportunity to participate in question and answers at the end of the Grand Rounds today. We also have a couple opportunities to participate in Poll Everywhere questions, and you'll get some instructions on how to do that. And I would encourage you to take advantage of those as so we can hear about what everyone's experiences are like. So without further ado, I'd like to turn it over now to Dr. Gewirtz O'Brien, who is going to start us off.
Thank you, Dr. Nathan. So as Dr. Nathan mentioned, we are going to be talking about pediatric telemedicine in ambulatory and inpatient settings during COVID-19 and beyond. And we have no disclosures, and we won't be discussing the use of off-label products at all. So I wanted to start us off with some learning objectives. We're really hoping that you'll walk away with an understanding of the evolution of telemedicine practice before COVID-19, but then also since COVID, in both pediatric, ambulatory, and inpatient settings. And we're going to discuss kind of the national landscape, but also the local landscape and how we've evolved and innovated here at the U. We'll also describe 3 elements of best practice for effective telemedicine visits. And specifically, we're going to hope that you walk away with some practical tips after you leave here. We're going to discuss advantages and disadvantages of telemedicine in pediatrics. And we'll propose applications for telemedicine after the COVID-19 pandemic for your practice. So here's our roadmap for today. I'll start us off with a brief overview of the pediatric telemedicine landscape, kind of the past and the present. Then Shawn will talk about ambulatory pediatric telemedicine, again, nationally and locally, and review some of the literature and provide some practical tips. Megan will talk about inpatient pediatric telemedicine and even some exciting innovations here at the U. And then the future of pediatric, I'll close with the future of pediatric telemedicine. And again, we'll invite you to engage in some reflection as we go about how you might apply this for your practices. I wanted to start us off by getting us on the same page about what we mean when we say telemedicine, because there's a lot of terms that are kind of floating around out there. For the purposes of this discussion, we're referring to telemedicine, meaning all care models that use an electronic transmission of healthcare data. And we typically break this up into 2 main types. One is synchronous or real-time transmission of data. These are things like video conferencing, telemedicine, and remote consultation. These are the things that often come to mind for most people when we say the term telemedicine. Asynchronous telemedicine are things that are store and forward. So essentially, this is similar to what dermatology has actually been doing, where they have a photo that a patient takes at home and then can forward and somebody can review later on. E-visits and e-consults also work in this way, and we've seen some large advances using robots actually in COVID-19 diagnosis and management for both in our system and throughout the country. And then diabetes pumps and glucometers are another example where a patient can upload all of their data and then a physician can review and send a message back. And there are really two core principles of telemedicine practice that we thought were important to highlight, and the AAP highlights this in their Pediatric Landscape article about telemedicine in 2018. And the first is that the standard of care is the same regardless of whether care is in person or virtual. And this is really important and has some big implications as we think about our system and about planning systems as we move forward. As an example, so I'm an Adolescent Medicine Fellow, and I have been working with Hennepin to kind of optimize the care we provide to adolescents. And we've been thinking a lot about adolescent contraception, the delivery of contraception to adolescents via virtual care. So how do we do this, and what can we do? What can we ensure? What would be the elements of a normal visit for an adolescent contraception? And when we're thinking about the guidance that we provided to healthcare providers there at Hennepin, we've thought about what would we provide in an in-person visit, and how can we ensure that the standard of care is the same when we see them virtually. And I'd invite you all to think about your own examples and your own practices and subspecialties about how that standard of care that you would do in person can be maintained virtually, because that really is a core standard of practice. The second core principle is that the site is considered the patient's physical location. And again, this has important implications, especially logistically, and has actually been a barrier in the past. So for licensing on a state-by-state basis, the state that the physician or the practicing provider needs to be licensed in is the place where the patient's physical location is. So for instance, if I'm a provider in Minnesota and I'm seeing a patient in Iowa, I need to be licensed in Iowa. Thankfully, there is some, thankfully during COVID-19, there's been a loosening of some of these restrictions. And even prior to that, there's been a rise in, there's been a compact that's evolved between states, and now more than, I think it's 29 states and the District of Columbia are involved in this compact that allow that interstate sharing for expedited licensing, but still, you need to be licensed in the place where the patient is. So that's been it's an important kind of thing to consider for both billing and licensure. So let's talk about the past of telemedicine, what the landscape looked like previously. It's really proliferated in rural health settings, in places where there may be limited access to subspecialty care and even sometimes to primary care. It's proliferated in schools, and I've been really excited about this in the pediatrics world because there's been networks of school-based telehealth that have been emerging across the country, where a provider is located on site somewhere else and students at the schools are still able to receive care. Teleconsultation for subspecialty care has also been evolving, and certain subspecialties are particularly have been advancing relatively quickly with this. Mental health and telemental health have really evolved. ICU care, and we heard about some exciting work going on here in our state in neonatology and earlier grand rounds this year. And even there's some adult ICU work that's going on here at the U. Cardiology, neurology, and endocrine have all thrived in telemedicine, both for adults and for kids. And then reproductive health, which is an area of interest for me, has really grown over the past decade. And in times of emergency, as we're seeing now, this has been used before in times of emergency when people aren't able to leave their homes due to fires, droughts, or other issues. I want to talk a little bit about barriers to proliferation. And these data come from a survey of telehealth providers across the country that was published in 2018. And it talks about barriers. So I'll walk through some of the common barriers that have kind of led to the slow and steady have kind of blocked the rapid explosion of telemedicine we're seeing today and made this kind of a slow and steady process. The first is reimbursement and business model sustainability. So prior to this, there have been many states where there has not been reimbursement parity for telemedicine and in-person medicine. So that means that people get paid less for virtual care. Thankfully, again, this has been lifted during COVID-19 to some extent, but has been a barrier historically. A lack of provider time and provider interest at the originating site has also been a challenge. There's a lot of provider apprehension about picking up new technology. We saw that with the rollout of electronic health records, and I think we've seen that even more so with providers with new technology and telemedicine, and that's really been a hindrance, and there's a lot of apprehension by providers about the quality of care we can provide. And we'll talk about how we can provide the best quality care today. Licensing, state regulations, and federal regulations have also been a barrier. Again, one that's been loosened during COVID-19, but still has been traditionally and historically a problem. And then technology, and this is technology infrastructure on the part of institutions like us. And we've seen this rapid growth of technology more recently, but it's also technology access and broadband access for our patients too, which still remains a barrier. Now let's talk about where we are today. So we're in the middle of the COVID-19 pandemic, maybe even in the beginning, some would argue. There has been this increased need for telemedicine where there's a risk of exposure for patients and providers. There's a limited availability of PPE, and there's a strain on systems. And at the same time, we're seeing barriers that are being reduced. So these historic barriers that I outlined are starting to kind of dissipate. So thanks to some changes at the federal level, actually, there's now reimbursement parity for both video and audio visits with in-person visits. So you can get paid the same amount. There's loosened technology restrictions, which had previously been a hindrance. There's increased access now. We're allowed to accept new patients with this. More providers are able to use telehealth, which previously had been a problem. There's been this rapid integration of technology, and we've seen that in our system, and it's actually really impressive. And then there is a flow of institutional and professional organization resources. So we're seeing this growth and support for providers to help with that apprehension about implementing this new and exciting technology. And as a result, there's been this explosion in telemedicine over the last few months. So what does this mean for us as clinicians? It means that we've had this very steep learning curve, and many of us on this call really jumped in and learned quickly and tried to kind of take the lead on this. But we're all learning this together, and the systems are still being built as we go, which is a huge challenge for all of us as clinicians. So what I'll invite you to do for this initial reflection is to think about what's actually gone well within your clinical practices. So try and think positively about patient, family, and provider perspectives. What we'll ask you to do is you can text Janna G 626 to 37607, or sorry, 37607 is the number, and then Janna G 626 is the code. Or you can go to polev.com /Janna G 626. And through both of these, once you enter the conversation, you'll be able to respond to this question with just a few words. If this seems intimidating, you're also invited to just put it in the chat, and I'll review those, and we'll come back to this question later on. And with that, I'll turn this over to Dr. Mahmud. I'll leave this up for a moment here.
Thanks, Dr. O'Brien. I wonder if it might be worth if somebody wouldn't mind just typing the codes into the chat there for folks, and then I'll do that
right
start
now.
Sharing my screen here.
You got it.
All right. And do you see my screen?
Yep.
Excellent. All right, so I'm going to talk a little bit about telemedicine today in the context of what we're doing in our ambulatory pediatric clinics. I'll start with some recent data on the growth of telemedicine in our institution. For some background, I just want to highlight some data on pre-pandemic patient experience with telemedicine. We'll discuss some of the some additional best practices for telemedicine and just some practical tips for your virtual visits. And then I will finish with some examples of how I think providers at our institution are using telemedicine creatively. So as Janna alluded to, we've had this explosion of telemedicine, and that's been going on in our institution. Plotted here are the percentage of total phone or video, as well as total video visits occurring in our pediatric ambulatory clinics listed in the bottom right corner here, starting from March 1st. And you can see pretty impressively, we went from about 0 to 60% utilization of the virtual visits within a week. And now since early April, we've been maintaining somewhere in the range of 70 to 80% of all these clinic visits as being virtual. I think plotting these data, it was a visually striking exercise for me, but it also helped me really appreciate how an organization can be nimble in the face of new challenges. And I think this is a testament to a lot of hard work done by many people, including our clinical support staff and schedulers and our nurse care coordinators, medical directors, administrators, and of course, all the people that have been doing and participating in these visits. So I think, whether or not we like telemedicine, we're certainly doing a lot of it. And it's likely that it's going to be a part of our future, although the degree and duration to which is yet to be determined. To help frame the discussion of how we can continue to improve as an organization on what we're now doing a lot of, we thought it'd be worthwhile to look back at some pre-COVID-19 data on both patient and provider satisfaction. There's actually quite a lot of data available on this topic, somewhat less so for pediatric patients. But I thought this was a nice example because it relates to satisfaction for using telemedicine in patients with chronic medical conditions. And we obviously do a lot of that kind of work here at our institution. This was published from 2019 and is data from the first year of the MGH telehealth program, in which both patients and providers were surveyed about their experiences after the first year. There were physicians from multiple specialties, cardiology, neurology, psychiatry, and others that were trained in virtual visits, and then established patients requiring follow-up care for chronic conditions who were deemed medically appropriate to do so were offered virtual visits. And then of the 254 patients that responded to surveys, about a quarter of those were pediatric patients. The data were overwhelmingly positive. Shown here is the percentage of either patients or providers from 0 to 100% that thought that the virtual visit was either better, not different, or that the office visit was better in dark, medium, and light blue respectively. The bottom line is that here only about 20% of patients felt that telemedicine was inferior to an in-person face-to-face clinic visit for follow-up. When it came to confidence in showing physical exam features, about 50% of the patients, well, I should say first, about 40% of the patients here indicated they didn't feel that during the course of the visit they had a physical exam sign. But of those who did feel they had one, about half felt that the virtual visit was somewhat inferior to an in-person visit, which is maybe not surprising. Interestingly, physicians were somewhat less likely to feel that way. When it came to the patient confidence in the overall encounter, though, pretty strikingly, over 80% of the patients surveyed felt confident that their problems and concerns were being adequately addressed. And strikingly, almost 70% reported that they would rank it a 9 or a 10 on a scale of 0 to 10, with 10 being best. Nearly 95% of the patients would rank it better than a 7. There's certainly a lot of data from studies of adult patients showing benefits of utilizing telemedicine to augment the care of patients with chronic conditions. Fewer publications have focused on that in pediatrics, but there certainly are still studies out there. And I suspect a lot more are going to be coming in the coming months. But I really just wanted to use this data to sort of highlight that important outcomes and benefits that we all care about aside, it seems clear that patients and providers do really seem to like telemedicine overall and have confidence in it. And I think that that's a good thing in the setting of this pandemic. So just to expand a little bit on some of the core best practices for these virtual encounters, the American Telemedicine Association has published some core best practices, and we're going to provide you guys with some links for some of this information. But I wanted to highlight like 3 of the most important core best practices. I think the first is ensuring that we always maintain patient consent, privacy, and confidentiality. Consent for a virtual visit is an important feature, and that's something that the medical assistants are doing in a lot of our clinic workflows. but it's the responsibility of the providers to make sure that privacy and confidentiality are, of course, maintained. It's also really important to make sure that a triage plan is in place to ensure that patients can have an in-person consultation if needed. And then I think it's really important, as Janna mentioned earlier, to ensure that the virtual visit follows all those relevant standards of care for both diagnosis and management of any of the conditions that are potentially addressed in that visit. We wanted to offer some additional tips on communication, and some of these are from our own personal experience. Others are described elsewhere. I think in general, I've found it helpful to introduce the concept of workflow of a video visit to a family. It also gives you an opportunity to address any audio-visual problems that up front that might be standing in your way of completing a good exam. And then we'll talk about some additional tools I think that can be useful in a minute. One subtlety with telemedicine is that it's pretty easy to appear distracted if you're breaking eye contact to look at the chart, for example. And for this reason, sort of narrating what you're doing if you are looking away can be really helpful. Let me just look at your last CBC for a second and make sure that your hemoglobin was normal. Or if you need to type something, let me just jot that down briefly. When communicating a complicated assessment and plan, I think many of you that have tried this have found it challenging, but I think that essentially all the same strategies that we use in in-person visits are used, just amplifying them somewhat to make up for some of the deficits in nonverbal communication that are imposed upon us by these video conferencing platforms. For example, we can't see nervous legs shaking underneath a computer desk. We might not pick up on a quiet sigh that isn't enough to trigger a microphone. I think we've all experienced how virtual interruptions on Zoom or in an Amwell visit are sort of more pronounced. And so for that reason, speaking more with deliberate, more frequent pauses seems to help. And then I think it's important to point out that we should be attentive to potential health literacy issues, particularly because this technology could amplify some of those issues somewhat. For example, we might want to, in a family with a child that has a complex medical condition, if the family is distracted by the technology of setting up the virtual visit, we really may want to use some of those old techniques like teach back, or better yet, have them write down the plan and teach it back to you. Or in some cases, maybe having nursing staff make a follow-up call the next day. I think it's really important with any of these virtual visits before we wrap up that we confirm that the patient and family feel that the virtual visit was adequate to address the needs. On the issue of eye contact via the webcam, one group actually evaluated this in the setting of a controlled study. Volunteers were asked to rate the perception of eye contact, and the camera position was then altered with respect to the provider. And they found that about 7 degrees above eye level was ideal, although I don't think that's drawn to scale in this image here. They did emphasize quite a lot also that increasing the horizontal distance between the webcam and the subject improves the perception of eye contact. And for those of us using laptops, this can be particularly challenging. It's even worse on a smartphone. But as you can see here, physically lifting up the laptop off the surface of the desk can help somewhat, although certainly there are fancier options. I think another important factor, though, is optimizing where you're looking on the computer screen. So we only are really making eye contact if we look directly at the webcam, but we're human beings and we like to see our patients' facial reactions, which makes that challenging. So sort of a happy medium that I've found is that when I'm at a point in a visit and I really want to make good eye contact, I'll sort of shrink that patient's video window and really center it directly underneath the webcam. And that sort of allows me to find a balance with still watching facial reactions, but also making quote unquote eye contact. And you can also test out and find where the sweet spot is on your own device with, recording a Zoom meeting of yourself or taking some photos. The American Telemedicine Association also has some basic recommendations on setting up the home office. Not surprisingly, some things like good lighting and neutral wall colors are favorable, along with a lack of clutter. My wife did strongly recommend that I take down all my Taylor Swift posters at the beginning of the pandemic. I think that was sound advice. Patients do particularly not like seeing open doors in the background. That's a privacy issue. And another issue with respect to lighting is that moving objects can create quite a bit of change in the way that your webcam looks. If you are so inclined to try and improve your lighting, I think the following examples can illustrate how indirect lighting works nice, particularly to get rid of some of the glare from the computer screen on your face. So here I asked a biologically obliged volunteer to demonstrate this, and we had the overhead lighting sort of limited in the room, and you can see that diffusing the lighting from that desk lamp in those bottom 3 panels really does help to even out the highlights on the face and eliminate shadows behind the subject. Some additional tools that I think can be really helpful to us in these virtual visits include the following. I mean, first, keeping in mind that utilizing additional technology in the home can be great. So if you're trying to do a virtual exam on a laptop in a small computer room, or the patient's on a laptop, that can be challenging. So you might consider asking that parent, is there a smartphone that we could patch into this call as well? Ask that parent to toggle the camera around and mute the microphone and lower the volume to get rid of feedback, and then sort of have them be the camera operator once you move on to the exam part. A change of clothes is also really quickly done at home and may facilitate a better exam. A cell phone flashlight or an old school flashlight, I'm sure, is something that many of you have asked patients to retrieve. A white piece of paper can be useful, particularly to white balance the webcam, and it sort of also helps you to calibrate your interpretation of color if there's something that you're looking at. And then, of course, a ruler can be useful. So in rheumatology clinic, if we have patients with temporomandibular joint arthritis, we will frequently be measuring their maximal incisor opening, how wide they can open. And we've just switched essentially to this point of having the parents measure it right in front of us. This is just a short video that features a couple of additional volunteers to really illustrate how tangential lighting can highlight some things that are sort of hidden on a webcam otherwise. I think a lot of the parents out there may know that word, tangential lighting, but it's also just so easy, since we have a webcam too, to just model what it is that we want these parents to do. Few technical tips just related to connectivity and the telemedicine platforms. I think most of you have realized that optimizing internet connection is important. They publish about 3 megabits per second being required, but I found that even going from 30 to 300 megabits per second, going from my Wi-Fi to an Ethernet cable, does seem to make a difference. Amwell, as you know, is the preferred platform. And I think overall it works well, despite some of the technical glitches that we had up front. One tip that I think can be helpful is to send yourself a text invite at the start of the video visit, and that'll allow you a way to quickly reconnect if the call is dropped. A dual monitor setup also works well with Amwell, just remembering that the patient window needs to be on the same monitor as the webcam. Doximity is a free app-based service. You need an app on both ends, where Doxy.me is a web-based platform. And both of those work well as backups. In terms of the virtual exam, there is a template available for you if you're so inclined, Video Exam Virtual. This is not it here, but I didn't want to overburden you with detail, but just use this sort of as a way to illustrate that with some creativity, and in some cases involving the patient, for example, for a lymph node exam, an abdominal exam, you really can document a 12-system exam that I think many would agree is probably adequate to assist in medical decision-making for a variety of problems. This is by no means to say there are not limitations. Obviously, we're not able to obtain a complete set of vital signs. We're missing out on doing ear exams. We can't auscultate. I just wanted to move on now to a few examples of how people are modifying their workflow to continue to take care of children in our clinics. In rheumatology clinic, as a surrogate to physically examining joints, we have used essentially a modified version of a musculoskeletal screening exam that was designed for general pediatricians. It actually has been shown to perform almost as well as a pediatric rheumatologist. The beauty of this exam is that it almost entirely depends on active range of motion. And here the volunteer is just demonstrating active range of motion throughout the neck, jaw, and upper extremities. I'd have to pull out the cell phone or come up with some other way to do the lower extremities there. And using this kind of approach in rheumatology clinic, I can say that we're absolutely still diagnosing arthritis and other conditions. I went back through the 4-week period beginning April 6th, and we saw 32 new referrals in that time frame with virtual consultation. 69% of those patients had abnormal physical exam findings, which were apparent, and 50% of those patients had a new rheumatic diagnosis or planned follow-up with rheumatology as the result of that visit. I think dermatology is doing a great job too adapting to this technology to overcome the limitations of video quality. As we talked about earlier, they're using this asynchronous model with store and forward. And essentially the physician gets a chance to review some basic photos and basic health history. In some cases, start a topical treatment just on the basis of these asynchronous encounters. But if the condition is worsening, as illustrated in the photos here provided by Dr. McGinnis that show this adolescent with some red inflamed toes, then escalation to an in-person visit and doing more diagnostic evaluation quickly can be done. This young lady had a biopsy most consistent with pernio. For anyone who's interested, her COVID serology is pending. Just some other examples. Dr. Beising from pulmonology tells me that he's seeing benefits with his patients with tracheostomy and ventilator dependence. Particularly those patients have to travel with a ton of equipment. So if they're doing well, they love these video visits. He's also currently providing care to a child in hospice via telemedicine. Dr. Rowe from nephrology tells me that she's really enjoying the opportunity to watch her patients use their home blood pressure cuffs and identify problems with that. She's also getting better insights into medication adherence and clearly sees an improvement or convenience for her families that live far distance from the university. And Dr. Larson-Nath from gastroenterology is seeing quite a bit of benefit in her short gut patients that are having intestinal rehabilitation therapy. She's found that video exams are usually sufficient to get a good look at a central line and a G-tube. She's also found this to provide some good opportunities for coordination of multidisciplinary care. Recently had a combined visit with GI, oncology, and surgery. So if there are no questions right now, I will turn it over to Megan to talk about some inpatient telemedicine.
Shawn, one of the questions that came through on the chat is about teach back, and if there's any thing that you've seen about using a video for teach back, like through MyChart or anything like that.
You know, I didn't come across anything specifically that there would be a different technique. I think that, you know, you can use it the same way in a virtual visit than you can in the office. That would be my take.
Someone would like you to say again what the rash was on the kid with the maybe COVID toes.
Oh, pernio, also known as chilblains, can be associated with a variety of autoimmune manifestations, but can also be associated with COVID, as we're finding out.
I think that's what they're talking about. They might have also been asking about that exam that had a acronym. The
virtual exam.
Yeah.
It was PGALs, I think, was probably the question. And we're
Oh,
happy
the
to
musculoskeletal exam. I'm
Yeah.
sorry, PGALs, or pediatric gait, arms, leg, and spine.
Yeah, and we'll post some resources about about TeachBack and a little bit about PGALs exam in the chat.
All right, so I will be presenting on the inpatient telemedicine. Can you all see my screen? Good. All right, wonderful. And some of the outline for my discussion will begin with the definition of inpatient telemedicine, some of the benefits that inpatient telemedicine has on the COVID-19 pandemic, and then to discuss some of the evidence base behind telemedicine as it pertains to interdisciplinary care, the feasibility and acceptability, quality of care for the patients, and cost and resource effectiveness of it. And then also to give you guys some insights on what we are currently doing. So similar to the ambulatory definition, inpatient telemedicine is defined as the transfer of medical information via telecommunication for hospitalized patients. And the two different platforms that are used can be phone or video technology. The stakeholders in the inpatient telemedicine include the care team members, patients, families, both that are in the hospital with the patient, but also at home. So during the COVID-19 pandemic, our overall goal has been to minimize the in-person visits while in the hospital. And the purpose of this is to reduce bidirectional risk of COVID-19 transmission, and also to conserve the PPE to allow the people who are currently in-house to have those resources available. And then also to decrease the number of providers who are being quarantined or ill, to ultimately allow better access to those providers. COVID-19 has caused significant changes in how families and caregivers are able to participate in inpatient rounds. Currently, COVID-19 visitor restrictions only allow one visitor per pediatric patient hospitalized. This can be very challenging for families who are accustomed to having multiple caregivers present during the rounding process and helping with the decision makings for their child. But telemedicine technology allows these caregivers to be involved remotely. There's also the challenge when it comes to education during COVID-19. Currently though, we have a few sub-intern medical students rotating on our general pediatric inpatient team at Masonic Children's remotely. The sub-intern is designated to pre-round and present on patients just like normal. However, the senior residents are acting as a surrogate examiner to do the in-person exams. That is not something that the sub-intern is able to achieve, at least in part. And ultimately, the sub-intern is still having opportunities to think critically and participate in the care of the hospitalized children. Just moving on to some of the research that's been done. A lot of the research articles that I had found talk about how inpatient telemedicine can impact interdisciplinary care, especially at remote locations. Ultimately, it can allow for the pediatric subspecialties to provide services in those remote locations, both those that are in a rural location, but also the urban hospitals that just don't have the pediatric subspecialist. This ultimately can decrease the need for patient transfers and increase the use of the hospital beds, both in the rural hospitals, the urban hospitals that don't have the pediatric subspecialist, but also to help with the census at the tertiary centers, ultimately providing better care to all of the facilities. From the pediatric subspecialist end of things, it can also be of benefit if you have multiple physical locations for rounding, so that you can choose to use the technology but not have the extra drive to go to the different locations. And I have actually been piloting some of the inpatient consultation services at the U, and as I have participated in it, I've been noticing how there is a good efficiency that comes with the technology. One of the big questions about inpatient telemedicine is whether or not it is feasible and acceptable. As a pediatric rheumatologist service, we've done a handful of these inpatient visits at this time during the COVID-19 pandemic, and it's actually been all on non-COVID-19 patients for our services. I have routinely asked for feedback about what the experience was like for the family as well as for the inpatient team. One of the common concerns that has been posed by some of the residents is that they worry that their exam is just not sufficient enough compared to the subspecialist exam. And there has actually been some research done pre-COVID that discusses this concern. And the study that was done is it was a survey-based study done on 25 adult patients undergoing stem cell transplant to address the question of feasibility and acceptability for inpatient telemedicine. The patients used telemedicine while at a remote hospital to connect with transplant physicians at a tertiary center. This study found that inpatient telemedicine is feasible and acceptable. Of the 54 providers surveyed, only 13 felt that some portion of their exam was limited, and no provider felt as though they were unable to adequately manage the patients. I have also had very similar experiences to what the study had come about, concluding about the feasibility piece. And out of all of the patients that we have provided consultation for in the hospital, all of the exams that we've been able to achieve have been sufficient to help with our medical decision making. The other part of the study that was done on the stem cell patients' telemedicine experience was on acceptability. And the acceptability seen in this was based on a survey of the provider and the families to say how much they enjoyed or did not enjoy the visit. And not surprisingly, the families actually seemed to like these a little bit better than the providers. And one of the things that we were told by a PICU family who was consulted on was that the mom really loved it. She said, "It is as if your minds were present without additional exams or disruptions." And I think that was really insightful to hear, because I hadn't really thought of it like that. Moving on to the quality. So we've talked so far about feasibility, acceptability from the perspective of the patients and the providers. But knowing whether or not you are providing quality care is really important. Several weeks ago, the NICU providers from Mayo had presented at Grand Rounds. And they had presented this data, so I'm not going to go into it extensively. But the thing that they were able to find is that using this technology decreased the time to effective ventilation by half, and it minimized the number of intubations that were occurring at the remote hospitals. So really showing that we can provide quality of care, even better quality of care in some situations. So inpatient telemedicine thus far, with the things that I presented, have shown feasibility, acceptability, and quality. You may be wondering if inpatient telemedicine is cost and resource effective. And there was a study done in Australia that shows that it can be cost and resource effective. The patients in the study were located remotely and received consultation from a tertiary burn unit. By using the telemedicine technology, there was a significant decrease in the number of transfers to the tertiary center from the rural hospital. And then also a reduced length of stay in total compared to what would have been expected for those patients otherwise. Ultimately saving a lot of money, $1.2 million over that 7 to 8 year period. So just moving on to what we have available for all of you now. So we have a platform on the inpatient side that's called Polycom. And it's the setup is where there's an iPad in each patient room that can be accessed remotely through simply going onto your internet browser and typing in join.fairview.org. Once you get into that actual system, you're then linked with the iPad that's in the patient room. This can be used remotely at your house. It can be used within a hospital and also at patient homes. So it allows for all different providers and care members of the patient to be involved in the care. It was initially started to focus specifically on the COVID-19 patients, but now it's being opened more broadly for subspecialists to also use for consultations. As far as the logistics with documentation, the only thing that you have to do differently is to make sure to include the special dot phrase. You can use your own templates that you normally do and then type in the .COVID-19 inpatient virtual. You don't have to always type in all of that, but .COVID-19 inpatient, you'll get it. And then there are also other consult notes, and we'll provide all of these resources. When you put in that special dot phrase, it actually triggers the coders to review the virtual visit. So the coding piece is more simple than you think. You will just put in inpatient consult as the code, and then it triggers that process to occur. And right now, the virtual and telephone interactions are being billed equivalent to the in-person consultation, but we'll see where that all evolves. And then I just wanted to introduce this really exciting thing that Dr. Pitt has really started up and created on his own. It's called Q Rounds, and the goal of Q Rounds is to provide real-time updates for their rounding time. And so it's a text message that gets sent out to the family members, the nurses, and really anybody else that might want, the team might want to know about the rounding time. And then it can integrate family-centered rounds for the care team, learners, and family members. So they text out a code and they can enter into, or they can type or click on the link that will allow them to get into the, currently it's Zoom meetings that are being used, but I think down the road we'll probably have to adjust that piece. And then the platform also allows for families to text in any questions that they have that can be saved to pop up. The actual text message pops up at the time of when the providers are physically rounding on that patient. And Dr. Pitt said that he would be around kind of at the end to talk about this more. I'm really excited about it though. And that's all I have. So I will shift it. Let's see. There we go. Now, Dr. Ryan, go ahead.
Mute and present. Perfect. Thanks so much, Dr. Ryan. So I'm taking the last leg here, and it'll be just a few minutes thinking together about the future of pediatric telemedicine. And as I've mentioned, I'm really excited about the future, and it wasn't something I was expecting when I first kind of dived into this world. And one of the things that has really gotten me excited is that the young people that I work with have been asking if they're going to be able to continue to be able to see me for mental health visits, for anxiety concerns, for contraception questions in the future. So I'm hearing this, as usual, I'm learning from the young people that I work with, that they actually really like this. And it made me think that maybe there are some ways that we might be able to take some lessons learned during this difficult time and move forward. So now we're going to think together about how we as an institution, as a department, might move forward. So first, I wanted to share that I'm not the only one with the experience of having only hearing some positive things from patients. What I heard from all of you, these were some of the responses you shared, is that virtual visits have really allowed multiple providers to participate in a visit, that that some of the fewer appointments maybe are being canceled related, especially in medically complex or medically fragile kids. It's allowing kids that have, somebody said, heavily equipped kids to be seen, and that it's really promoting or helping with families from greater Minnesota and reducing some barriers to access. So I'm excited to see that some of you are having some positive experiences with this as well, even in this difficult time, and even though it was kind of a rapid integration of technology. That being said, let's think together about the future. So I presented these historic barriers before here on the left. And I mentioned that in the present, a lot of the restrictions have been loosened and a lot of the issues have been improving, meaning we now have reimbursement parity at most states nationally. A lot of the regulations and licensing issues have been loosened. We don't know what the future will hold for those. And actually, Dr. Neglia brought this up in the chat, which is we've heard that some states are actually having their reimbursement restrictions already rolled back. So we have to think together about what it's worth advocating for and think about how that'll impact our state if we decide to move forward with telemedicine. Minnesota, thankfully, is on the cutting edge with this, and that we had some parity laws regarding telehealth even before all of this, even before COVID-19 began. With respect to provider skepticism and concern, my hope is that by jumping into this, there's still some concern, but that we're also learning, and we're learning together and making this becoming a little bit smoother. And the technology infrastructure, this investment has now been made, so we may be able to leverage it. With respect to patient digital access, it's still an issue. It's still an issue for some of our patients, and we need to think together about how we can equip patients that may have limited digital literacy or digital access. But let's think about some opportunities. So certainly there are opportunities for improved access for children and families. As some of you mentioned, your children, the families you serve in greater Minnesota when distance is an issue. And even we've discussed last night, and it's been discussed that when weather is an issue and we've had to rapidly reschedule visits, that might be a barrier that could be overcome with some hybrid of having telemedicine available. Certainly there's an opportunity to expand our subspecialty remote consultation and maybe even improve our outreach to low-resourced rural or sites that are at a distance. And this could be considered something moving forward even after COVID-19. And then there is this opportunity that I'm excited about to potentially expand some of the community-based and school-based care that we provide as a system. Absolutely, there are challenges, and we've discussed some of them today. We hope that some of the practical skills that we talked about have improved some of, made you at least convince you to some extent that some of these are not insurmountable, but certainly technology woes are still an issue, and we'll continue to hopefully overcome them, but they're absolutely a challenge, and we have to continue to work on them and improve our systems. Regulations and reimbursements will continue to be a challenge and likely a lever of advocacy moving forward. The physical exam is something that we're all working on our skills. How can we continue to provide the standard of care with a limited exam or an exam in a different way, and how can we be creative about this? I mean, I learned a lot even as we were thinking about this talk together from our peers, and I hope that we all will kind of think together about this. And then access to labs and imaging. So in patients who do need labs and imaging, how are we going to do this well? Or immunizations, how are we going to do this well remotely? I'd also like to briefly pause and think about an equity lens. So there is great potential to actually reduce disparities and potentially improve access to care with telemedicine. But there's also a risk whenever a system is implemented rapidly that we could further perpetuate inequities. So if there are structural problems with our system that don't allow for people with limited digital literacy and access to access us, or when there's limited health literacy or language barriers, when we don't have systems that actually allow support people, all people, to be able to access them, we could potentially further perpetuate inequities. So we have to think about this as we expand and grow our systems. The future costs, so this is a question that comes up a lot, and honestly, it depends. We don't have a lot of great data on this. It's going to depend on whether or not reimbursement continues to have parity nationally. It's going to depend on regulations. It's going to depend on whether or not there's a need on the epidemiology of COVID-19. And it's going to depend on whether there's sustained funding. Right now, there's been a large investment from the CARES Act and from the Connected Care pilot program over a 3-year period, but we don't know whether or not these will persist. So still a lot of unknowns with respect to cost. With that, we want to close by just kind of recapping where we've been. We've talked about the evolution of telemedicine practice before and the explosion during COVID-19 in pediatric settings. We've discussed some elements of best practice, and hopefully you're walking away with some exciting tips to bring with you. We've discussed some advantages or disadvantages, and we proposed some application for the future of telemedicine. We'll also share some resources. This is for the American Academy of Pediatrics has a great toolkit on telehealth, and so does the American Telemedicine Association. And of course, there are some U of M specific telehealth resources that we're happy to share with you too. And with that, we'll invite you to engage in some discussion and a final reflection. So if you text the same number you did before, what do you see in the future of telemedicine? And you can text or go online and share with us where you see this going. And we'll look forward to answering some questions from here. And I've actually included the link here in case there are questions. So yeah, with that, we'll take some questions and discussion. Thanks so much.
I thought there was a good question, just feeling like it's slower. Someone shared that it just feels like it's taking them a lot longer, or just the structure of a virtual day feels very different than a in-person day, where you might use that little 10-15 minutes while they're getting room to kind of catch up or quickly review the patient's chart. Any sort of tips or best practices that you guys have learned over the past 6 to 8 weeks that kind of help with that virtual flow?
So I personally think that this question is right on, and I think we probably all experienced this same phenomenon, which is that it does actually require a little more preparation time before visits, and I think this allows you to continue to be efficient as you move through your schedule. I posted this on the question and answers forum, I think there is a little more discomfort in the kind of dead air time when you're engaging with a patient on video chat, is if you have to go back and look at either past history or previous lab results. So again, just to reinforce kind of what Dr. Mahmud was saying earlier about discussing and making sure that patients know what you're doing when you're going through the chart. But I would agree that it's sort of paramount to have that preparation time to go through and set up your notes and previous patient encounters so that you're ready to go on those days.
It can also be helpful to do a lot of the, or have the families send in pictures, send in videos, get the labs beforehand if it's a routine visit, and that can really expedite things and maybe minimize the use of needing to send in a separate letter. I know that that's been helpful in my follow-up visits.
This is Jordan. I was just going to chime in to a different question that was asked about our inpatient consults available in non-COVID patients. The answer is yes, and that's what Megan was talking about. All of the rheumatology consults that she's been doing are on COVID negative patients. There are those extra iPads that are around. The initial units to get those iPads were the COVID cohort units. but I believe there's a big order of iPads that are on their way to the institution that are going to be going to all units. So there should be capacity for inpatient consults all over the place. And Mark Slice was specifically asking, so just to point out, at Fairview Ridges, for example, we're talking about having Peds ID consultations there, and that's a unit that had received several iPads as well. So there's iPads going across the system.
And Dr. Mahmud and I are available for any help if you guys have questions specifically about how to use the technology or some troubleshooting things for the Polycom.
Let me chime in also about Polycom. People are probably anxious about, hey, I'm just learning Amwell. Do I have to learn a whole new platform? It's pretty intuitive. There's information sheets. What Shawn had put up there was a or what Meghan had put out there was a quick intro sheet, but there are info sheets on each of the units. It's intuitive. We can patch in family members, as Meghan had been saying. We can patch in an interpreter as well through that technology, and so it becomes quite handy and a useful way to communicate with families. So with COVID patients, I'll share that the hospitalists have been using them quite a bit. With COVID patients, it's really been an opportunity not to go across that threshold. So to avoid PPE usage, to avoid the healthcare worker exposures and exposing everybody as we're entering and exiting those rooms.
Any insights into technologies that might be coming where you could do more of a physical exam at home, either auscultation or looking in an ear?
There certainly are stethoscopes that have been around for quite some time. There are ones that are can plug into a USB port, for example. There's additional software that's required, and I think that it's something down the line, but I think could be potentially very helpful for some of our colleagues like cardiology and pulmonology. And I know that there are some ways of doing an ear exam. That's not something that I've ever attempted, or really know much about. I'm curious, Dr. Borman-Shope, have you?
Well, that's why I love working with trainees, because my continuity resident just showed me there's the otoscope that you can buy from Amazon that takes pictures and sends it right to your cell phone, and the quality was incredible. So I think there is a lot of technology out there that we could probably be taking advantage of.
Yeah, I think this really gets at that standard of care thing. So we kind of think about the standard of care as a core principle of telehealth. And the question is, how can we be creative and use technology to our advantage and see if we can do this? And I too have heard about and used I've heard about the otoscope apps and things. And I think there really is this opportunity to kind of play and learn, especially when the system is necessitating it. And then you can see here, I'm sharing the screen of what people are writing for the future. And people are talking about potentially a hybrid, using MyChart, thinking about quicker discharges and fewer inpatient stays. So meaning there is this opportunity to build and use technology in a positive way too, even though it can be challenging. But I agree. I've been learning from friends and colleagues too of new tips and things too.
I'll add, there's a lot of technology that's been built out, made for more of the medical centers. So, think tele-ICU. There's a lot of information that can come in, to the ICU doc who's remote from the patient. But for clinic visits, you have a patient at an outreach site. If there's a nurse practitioner who's there or a nurse who's there at that site, able to, to put the stethoscope that sends the remote auscultation signals to the person who's away, or the otoscope that goes into the ear and takes pictures. Those are really designed more for the clinic kind of setting. And I think we're just in this explosion of, can people implement some of these technologies at home? It's yet to be seen.
All right, well, I think we are just about at time here. So I want to thank all of our presenters for giving us some really great practical tips, as well as the lay of the land and what the future might look like. And I'm sure there'll be more to come.
Thanks,
All right,
everyone.
thanks, guys. Great job.
Thank
Have
you.
a great day.